Assalamu alaikum. Welcome everyone on board. We will be discussing some scenarios related to liver. Um, so, may I just know who among you would like to volunteer to speak out? Zishan, can I have you on board?
Yes, sir.
Okay. So, usually, liver disease patient can be asked or you in the exam in both long case as well as table viva. Okay. So, usually, what do you think? What would be the scenarios which can be encountered in such patients? Usually, commonly, what may be the common questions about liver?
So the common question in the liver, in short case, it could be emergency, like patient can be bleeding with hemoptysis or melena.
Hemoptysis,
In short case, sir,
hemoptysis,
hemap,
hemoptysis,
hemap,
not hemoptysis, hematemesis.
uh,
Just a
then they could ask about the multi-systemic effect of liver failure, chronic liver failure on other organs. And they could ask about the Child-Pugh score, and they can have a patient of liver failure, chronic liver failure with emergency surgery,
okay.
for emergency surgery. Yes, sir.
Okay. So, yes. So, what are the problems in liver which are related to anesthesia? Just if we can just chalk out the most important ones. Yes, Zishan.
Yes, sir. Relevant to yes. So, when a patient comes with the liver disease, it's basically a multisystemic disease. So it has a effect on each organ of the body. The organs which are most concerned for the anesthetist is the airway, sir. In this patient, the airway problems could be there because there is a risk of aspiration. So airway problems. Then they can have cardiovascular problems
Like,
in the form of patient could have a decompensated heart failure. Patient could be in a heart failure. There could be arrhythmias. Patient could have arrhythmias mm, and right heart failure.
very
Sir,
simple.
patient could have right heart failures,
Yes, right heart failure, like hemodynamic instability.
hemodynamic instability, sir.
Hemodynamic instability. Go very simple. You have told difficult airway, sorry, this one aspiration, but you have not spoken about very simple thing. If there is a enlarged ascites, okay, is it
Yes, sir.
a problem for anesthetist?
Yes, sir. Large ascites is a problem for it. Just as I said, it can have a risk of aspiration, early
No, no.
desaturation,
Come out
and
of
during
aspiration.
surgery.
Don't try not to repeat. Okay, try not to
Yes,
repeat.
sir.
So you have told one time aspiration, so it's not a good, because you know why I'm because I will just start shortly. So this is just a starter. Okay, so Sheher Bano, would you like to add something? You have raised the hand.
Yes, sir. A patient of liver disease can be of interest to us as anesthetists because of the drug metabolism that is dependent on the liver. The patient can have some coagulopathy because it affects the hematological system, and
Very good.
furthermore, it can present with complications such as hepatorenal or hepatopulmonary syndrome.
Very good. It's better. So you have added some things. Okay. So usually, remember one thing when they are asking about anesthesia concerns. So what is the easy way? If you will try to recall from the liver topic, it will be difficult. If you try to fit in our anesthesia steps, it's easy. Am I right? So if you are talking, you can go airway breathing circulation. You will not forget. You will not forget about intubation. You will not forget about analgesia. You will not forget about fluid. You will not forget about induction or recovery. Am I right, Zishan? Instead of just
Yes,
thinking
sir.
about liver, think about anesthesia steps. Because like any other laborer, we are laborer of conducting the anesthesia. So you will not forget your job. Am I right? You can forget liver,
Yes.
but you cannot forget your anesthesia. So instead of recalling from liver, try to recall from the steps of anesthesia. Okay. So you can start from optimization. What optimization can be done? then you can think about, now you will think about what can be done in each step. So optimization will be related to ascites, number one. Okay. Pre-op anxiolysis will be cautious. Okay. Then if usually elective surgeries will not be done unless the patient is optimized. Am I right? So usually you will have, like you were discussing, that maybe it is an acute operation, like for example laparotomy or any other emergency surgery. So usually emergency surgery will be the one which they will be asking you. This is one point. Then they can ask you about acute GI bleed, whether it is upper or lower. Then these patients will be coming for elective check endoscopies, whether it is upper or lower, to just either for banding or anything. Like this will be either, actually both are bleedings. Okay. And because of, as Shehrbanu mentioned, because of the coagulopathy. So, but one situation will be acute and one situation will be like in which either they are going for some banding or check. Okay. And then another aspect will be with the liver transplanted. So there will be something, certain thing which you need to have some procedures in a liver transplanted patient. Okay. So these patients, they are coming for, like sometime there is obstruction of any anastomosis they had done. So there are some strictures which are developed. So they are coming for, or a routine checkup as well. So there will be certain categories of patients you will be looking at. So because all the drugs are metabolized. So now this is one way of recalling that fit it into the anesthesia steps. Another thing will be, think about the synthetic function, what are other, the metabolic function, and what else you can say, the synthetic function with reference to bile and coagulation. Okay. And actually plasma proteins, there are so many other things, but to be on simple side, you will be looking in that way. So there will be certain things you can learn, you can just recall through the functions of liver. Okay. So just actually I just wanted to give you an idea first, so we will then explore further. Okay. Just a second, please. So any other scenario which may be asked in the exam? So now you should be thinking, again I'm repeating, emergency surgery, GI bleed. Okay. So these are mainly these two scenarios which are, now if you are reading this GI bleed, so the concerns in endoscopy suit. So endoscopy suit will be there. So then some people will be doing it under conscious sedation, or like you can say monitored anesthesia care. So this will be, so these things you may be asked. And because all the drugs are metabolized through liver, so whenever you are thinking about liver, just think about what you need to change, like any change in the muscle relaxant, any change in the analgesia, any change in the regional anesthesia techniques. Okay. So these will be things you should be noting out. So okay, coming back from another aspect now, like how to evaluate. So you used a word, child pox. Okay. So usually we label at as mild, moderate, or severe according to child pox score. Okay. So in child pox score, there is like bilirubin, encephalopathy, albumin. Okay. And this one,
Ascites, sir.
ascites
PTINR ascites.
and INR. Actually, the mnemonics never forget. So it is, for me, it is Mr. Bean. So it is the bean which I was trying to write. So so
Hmm.
it's always give nice to make this mnemonics. So in that, because I never repeat, and only the, so when if they ask you how to evaluate the severity of liver disease if you are in long case. Even then, you should be looking mainly in these things. And if it is stable viva, you don't need to tell, I will take history, I will do examine, because you don't have time. You don't have time. And this is the most difficult thing to summarize, or like you can say, what you say in our language, darya ko kuze mein band karna. To just summarize, put something very squeezed. Okay. So that is the problem. So in table viva, whenever they are asking you anything, you should be using this word, which I tell again and again, that you will evaluate on the basis of history, examination, and relevant investigation to see the severity of disease and look into consideration any reversible things which you can do. Okay, because in emergency surgery you cannot send the patient for echo, you cannot send the patient for anything which will be delaying. You cannot delay it, am I right? So but quickly you can do something, you can do an ABG, you can do a ascitic tap, you can start replacing some FFPs. So the correctable things. So actually, this word which I have told you just now is for every, not only this liver, for any topic. You can use this word, that I will be evaluate the severity of any disease according to history, examination, and relevant investigation to see the severity of the disease and anything we can optimize in the time permitted, whether it is an emergency surgery, whether it is an urgent surgery, whether it is an elective surgery, or whether it is a planned surgery. Because maybe if it is not emergent surgery, still you have some time. You can do a ascitic tap, and you can replace the FFPs, you can give some albumin, you can give some PCC, prothrombin complex concentrate. Okay, you can have some blood transfusion, you can replace or correct some of the acid based problems. So a lot of things you can do in allocated time. So I think this will be a very good sentence for you to make it for all the diseases, and try to make a 30 seconds to 1 minute answer for all common diseases. This will help you in the exam, because you will not be floating. You will be very concise and meticulous. Am I right, Sheher Banu and Zishan? Agreed?
Yes,
Yes, sir.
yes, sir.
Okay. So now, like, then you can further elaborate. If you know in table viva, you can make your answer that we will be looking, if they have given you a scenario of chronic liver disease. So the easiest way is to tell through this child puck score. If they are asking you, if they you saw a long case in it, then you have to go a little more details with reference to all the history taking. And then usually what will be that liver, whenever there is liver problem, there may be CNS in form of encephalopathy, CVS in the form of volume overload and heart failure and cirrhotic cardiomyopathy, and what else? This lungs. There is this hepatopulmonary syndrome in kidneys. There is this hepatorenal syndrome,
Hepatorenal.
and then there are metabolic and this electrolyte and endocrine. Okay, endocrine, metabolic, electrolyte, this fluid balance. So even you are taking history, please don't forget, you don't have to go in the too much details of that specific patient. Okay, you don't need to make to find proposal for that patient. You have to find the things which are related to you. That's the biggest problem which we do in long case, that whatever they are telling you, the common symptom, the common symptoms which the patient is telling will be one thing. Like here, maybe it is jaundice, hematemesis, melena, shortness of breath. Like it, whatever symptom they are telling, you will just explore that specific symptom a little bit, and rest will be the common things which will be there in any liver disease any patient, not even liver disease patient, any patient. You will be asking about the demographic data, you will be asking about the things which are related to you. So remember one thing, you should cram, or you should make a mnemonic for the common question which you will be asking to any patient, whatever it is. And then common 4 5 symptoms for each disease, which can be like shortness of breath will be there in liver problem, in heart problem, in kidney problem, in respiratory problem. So you should be knowing what questions you need to ask. How the shortness of breath starts? Is it associated with cough? Is it associated with orthopnea? It is associated with PND. And here, the different thing will be this pletipnea orthodeoxia, which is because of intrapulmonary shunting, and in which the patient will be more dyspneic when this sitting, and gets better when lie flat. Okay, so this is a little different, which is there in the liver problem. Same you can go for other systems as well. So chest pain or failure or whatever. So make a list of the common questions. This will help you in the long case. Okay. So we will just try to, because we have make a baseline. So now we will just have a look here at what we can learn, because yes, another thing, one will be acute liver failure. So acute liver failure will be either with the hepatitis or any other viral infection or paracetamol. So here your approach will be a little different, and you should be focusing on the King's College criteria or MELD score. So you will be looking at the liver transplantation, and if they are asking about paracetamol, so should be knowing what why. Can someone tell me, Sheher Bano or Zishan or any whosoever want to tell, why there is liver damage in paracetamol?
It's central lobar
What was it?
necrosis
Okay, continue please, Zunaira.
because of because of the depletion of glutathione
Okay,
and the accumulation of the toxic metabolite NAPKI that is
okay,
being degenerated by or metabolized by glutathione.
okay,
And we can give NAC or methionine in order to as a precursor for glutathione.
okay, okay. So
So it
so
depends upon also the dosage. Like, is the dose taken like at the same time, or it has been taken at numerous times, and then we have to do at 8 hours the paracetamol, the profile, the normal profile or low profile, what they call it,
what the
and
name
then
of
we have to
what the name of that thing which we use? It's called as, there is a
of
mechanism by which they are doing it.
we use methionine synthase, or we use the precursor, the
No, 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 no,
N-acetylcysteine.
no, 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 no,
You, the
no,
the
no.
normal profile for the
You are
paracetamol.
not understanding the question, Zinera. The
Hmm.
question is something else. I am asking, how will you, like you are telling about the time of and the dose. Actually, there is
Hmm.
a normogram.
Yeah,
Okay,
normogram. Yeah.
normogram which they do for paracetamol poisoning,
Hmm.
and they will decide according how much dose and how whether it will be effective or not
Hmm.
accordingly. So you should be knowing about that thing.
Yeah,
Right.
and it's
Okay.
actually the central lobar necrosis, no?
Yes.
Okay.
So that is actually the some more details about paracetamol poisoning. I thought to find it somewhere. I had put it here, but I'm not finding it where, in which folder I have put it. So, in your exams, they may be asking some more details about it, but usually in Pakistan exam, they will not be going into much details. But still, you should be knowing the basic concept of liver physiology. Okay, the liver zones, how you see, this was what I was talking about. Treatment according to the normogram, and it is time in hours. Okay, and plasma paracetamol concentration. Okay, so in that way they will be identifying the they will be, you have to give it or no. Okay.
No, so actually, for the paracetamol poisoning, if it's done like if you have clinical symptoms, then you should start the like NAC in any way. You can even give it even after 24 hours. Like till 24 hours, it's safe. But the thing is, like, they do the normogram in order to know how much the
Prognosis.
toxicity is there.
Yes,
Yeah,
prognosis.
exactly.
Yes, 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 you're right. You're right. You're right. So that will be dictating about the prognosis, and that will be also maybe because I have not treated it. Unfortunately, I'm not working in the ICU at all. So I have not actually in my career, I have never seen a patient with paracetamol poisoning. And so the thing which you don't do it, unfortunately, you don't remember only by reading. So you can just have a look about it, because this is the point. which they can ask. Zishan and Shehrbano, if you want to add something. Yes, Zishan.
Yes, sir. In the patient, when the case scenario will become, so our we should start by
Airway
starting our
breathing
case with
circulation.
airway breathing and circulation. Yes, sir.
Yes.
So and
That
then
will be the
definitive
common thing.
treatment.
Yes, but usually they will be the things which they can ask you is this one. The King's College, I think this is the one. Um, they will it no, it's not written here. If, for example, they can ask you how much is the safe dose, how much dose will be doing the toxicity, and how will you identify, okay, and how will you treat. So this is the common thing, which you, because the thing is that you should be knowing how different questions will be asked, okay. And if it is any other type of liver failure, similarly you will be approaching with the same approach, every breathing circulation, because another reason of acute liver failure is like viral hepatitis, so fulminant hepatic failure, okay. So you see here they can see indeterminate idiosyncratic drug reaction, ischemic hepatitis, hepatitis B, hepatitis A, autoimmune hepatitis. So you should be knowing the common causes of acute liver failure, and then you can find you see they will tell you the hyperacute, acute, and subacute, okay, and then diagnosis, absence of chronic liver disease, acute hepatitis with liver enzymes and coagulopathy, and any degree of mental alteration with encephalopathy. They will do the enzymes. Okay, so usually this ALT, AST, serum albumin, or this other metabolic problems will also be there. Okay, so these are that, as you see, full blood count to see hemoglobin, platelet count, and then serum electrolytes, ammonia, ceruloplasmin, alpha. This is to rule out the cause. Okay, pregnancy test, HIV, liver function test, PTT, ABGs, pH, paracetamol, and salicylate levels. So, uh, hepatic Doppler ultrasound to exclude chronic liver disease, and what they show, hepatic vein patency also assessed to exclude Budd-Chiari syndrome, which is the vascular cause, intra-abdominal malignancy, okay, and liver biopsy. So this is how they will be managing the to like separately if there is like edema, so mannitol or this one cerebral edema, maybe elective ventilation, okay. So that will be the way, and neuroprotection, like these are the common things which you can explore your answer accordingly, okay. So as they have written here about elevate head degree, yesterday we did neuro, so these are the same things. You have to maintain the cerebral perfusion pressure and avoid hypoxia and blood glucose levels. Mm, Here, by the way, in liver failure, there will be chances of hypoglycemia, okay, rather than hyperglycemia. So here, actually, you have to look for hypoglycemia rather than hyperglycemia. Of course, it is the common things to avoid secondary brain injury, but or not here in secondary brain injury, it will precipitate encephalopathy if it is not there. So these things can precipitate encephalopathy. ICP monitoring, respiratory. I'm just have a look and anything special which you should be knowing about it. Uh, Intra-abdominal hypertension secondary to bowel edema, ascites, pleural effusion. These are actually we will just try to have a look in the in the chronic liver disease. So ARDS can occur, patient can go in sepsis, and whenever there is, you can forget. So whenever if you use the terminology of ventilation, so you can tell that now this patient will be prone to develop ventilator associated pneumonia. This patient will be prone to develop ARDS, sepsis, okay? Because other problems will be going side by side, because all ICU patients, they have a common approach, okay? So any ICU patient, you should, I have discussed before as well, and inshallah, we will just have a look on general management of ICU patient. So you can have a lot of things over there as well, okay? And hepatorenal syndrome, as we know, that it is development of renal failure without pre-existing kidney problems, and there are certain avoidance, exclusion of hypovolemia or anything like that. We will just have a look here there as well. And nutrition related problems, infection, coagulation, you will correct it. And as we know, an acetylcysteine and then liver transplant. They will, I think it is posted here. You should be knowing about it. This King's College for paracetamol and non-paracetamol. So here it is pH, encephalopathy and creatinine and prothrombin level. And here it is a little different is age. Prothrombin time is the same. Bilirubin, okay. And time from jaundice to encephalopathy. And non-A, non-B halothane related. So these are the things which you should be knowing about. Common things will be the same. Common things will be the same, and you should be focusing more on the common things. Okay.
So I would like to add here about the
Yes.
King's College criteria. I have read recently they have changed some of the like they have replaced
Parameters.
the about the King's College criteria. They have replaced the the INR, I think,
Okay.
with the prothrombin. No, it they have changed it with something else.
You can post here in the chat box.
Okay, I will look. Yeah, they have changed it. Like they have modified it.
Okay. Okay. So we will just look at we will just chalk out what are the features in liver failure. We have discussed some of them. Uh, Zishan, can you tell how the portal hypertension occur in liver failure?
Sir, it's basically because in a chronic liver failure, there is cirrhosis of liver and fibrosis of the liver. So there is a backflow pressure develops in the portal veins as the consistency of a fluid in the circulation is lost when the blood vessels are in the liver. So back pressure develops in the veins which form the portal veins. So there is so this leads to portal hypertension. Usually it is more than I think so 15 mm of Hg, sir.
Okay.
And then
So
because there are some places where there is portosystemic circulation, so the back pressure leads to increase in the pressure in those portosystemic shunts places, such as there's esophageal varices, rectal varices, abdominal varices. So it leads to those bleeding, sir.
okay. So and also it will lead to ascites as well. Okay. So
Ascites.
how to treat portal hypertension?
Sir, they usually start
Beta block.
first. We have to control if there is a cause which is causing the liver failure. We have to treat the cause. Other than that, the medications which they give are spironolactone, beta blocker, and yes, sir, these two medications, sir.
Vasopressin, octreotide, terlipressin, octreotide they give for the control of portal hypertension.
And sir, there is also a surgical procedure which could be done, which could they could
What is the
create a
name of that
diversion.
procedure? TIPS.
Tips, yes, sir. Tips.
When you in the heat of exam, you can easily forget the abbreviation. I cannot forget that they asked me ERCP, and I had forgotten the name abbreviation of an ERCP in the exam. So always remember this. I think transhepatic intrapulmonary. What is the abbreviation?
There is transjugular
intrapulmonary.
intrahepatic portosystemic shunt.
Very good. Transjugular. Okay. Okay. So this is how, and then because it's not written here, I think I remember it was written in Morgan Sharif. What is the mechanism of development of ascites? There is one forward theory and there is one backward, something like that. Can you recall? Yes. Anyone else want to speak out? Zunaira, how ascites develop?
I cannot recall.
Sir,
There is activation of
ascites are
RAS. Sir, I've heard there is activation of RAS RAS, sir, RAS. So there is
Just a second,
aldosterone
Zishan.
increase. So aldosterone.
Just a second. Sheher Bano, you want to tell?
Ji sir, one of the mechanisms for development of ascites is decreased albumin synthesis, and that can cause decreased plasma colloid pressure. And secondly, there is an increase in the vascular pressure in the vessels due to resistance to flow due to the cirrhosis in the liver. That causes transudation of the fluid, and that also causes ascites. So basically, एक ये कि proteins कम है, colloid pressure कम है, और दूसरा ये है कि जो vessels के
Hydrostatic
अंदर
pressures
fluid
is more.
hydrostatic pressure है वो कम. जी sir.
And but also it is, as he was mentioning, because there is also increase in aldosterone and activation of renin-angiotensin activating system as well. This is also one of the reason for overloaded. So this is what I remember, the forward theory or backward theory. I don't remember exactly. You can read about it, because maybe they can ask you this question. You know, in the common long cases, you should not miss anything. Even you should be reading from the details from the medicine book. Of course, I cannot recall each and everything I'm giving you, because this is a common question. They will ask you how portal hypertension develop, how ascites develop, and then you can tell about how it is being treated. Okay. So a lot of factors will be from overload, and because there will be this extravasation, because oncotic pressure is less, so everything is going out. So intravascular volume will be less. So that's why when you induce the patient, there will be sudden hypotension. Okay, because systemic vascular resistance is also low, and if you are giving anesthesia medication, it will reduce the patient cardiac output will not be able to maintain. So this is another thing you should be knowing about it. So some we will just dig more into it. Like patient with the circulation, there is, you see, high cardiac output and low SVR, as I was telling you. In alcohol liver disease, hemosidosis are associated with cardiomyopathy. So like patient with advanced liver disease may have risk factor of coronary artery disease, because it's a sequence of evidence. Whenever there is a heart failure, there will be chances of development of arrhythmias and ischemia. Okay, so this will be our package which will be coming together, and we will just have a look on alcoholic liver disease a little bit. And okay, so this is there will be one physical effect on the respiration, that will be because of ascites. Okay, and because there will be more chances of infection, there is more chances of pleural effusion. Okay, and also pulmonary edema, and there is reduced FRC, and already hypo. And then the other thing will be, as we mentioned, discussed with reference to intrapulmonary shunting. Okay, so there is dyspnea, hypoxemia while sitting upright, which improves on lying flat. That is what is called as orthodeoxia. The presence of pulmonary, they can ask you this test, that the presence of pulmonary vasculature shunting is best detected on echo with saline bubble test, where agitated saline is injected IV as a contrast medium, and if it present, can be termed the hepatopulmonary syndrome. Maybe you should have just idea about how they identify it. Okay, in liver transplantation will be only option. Hematologically, that anemia secondary to bleeding or anemia of chronic disease. Okay, and also hemolysis through in the hyperalbuminism. So malnutrition also. There will be multifactorial. That this is I remember one of the question they can ask you why there is anemia and liver failure. So you have to tell these 4 or 5 reasons, which is there commonly loss as well as malnutrition, anemia of chronic disease, and hemolysis also. Okay, and then coagulopathy, that vitamin K dependent factor 2, 7, 9, 10, with the PT and INR, and this APTT will be more also. There will be thrombocytopenia and platelet dysfunction. Okay, so there is secondary hyperaldosteronism leading to water retention and hyponatremia, resulting in formation of ascites, as you were mentioning, Zishan. Okay, so usually
Yes.
here they are why they give spironolactone? Why they give this potassium sparing?
Because
Sir,
of
because it is antagonist of aldosterone, sir.
because its
Okay,
primary It's secondary hyperaldosteronism.
Yes, like this is one reason, but actually, whenever there will be more aldosterone, there will be less potassium because it will be retaining sodium and it will be kicking out potassium. So you need to give something to replace potassium. Okay, so this is another explanation. The same words which you are saying, I am giving you a different perspective. And a number of times, if they are giving loop diuretics, it will add insult to the injury. Already patient is hypokalemic and you are using loop diuretics alone, it can lead to more hypokalemia. So this is another reason. Okay. So this is another thing which you should be
Sir, I
knowing.
have a question here. It's
Yes.
spironolactone is still used, or it has been replaced with eplerenone?
What is this other one? I don't know. I'm sorry, I don't
The
know.
It's the same like spironolactone, but it has less effect on androgens.
Okay. I have no idea about it, Zanera. Because the only thing is that because I'm not doing ICU, unfortunately. So the people from Pakistan, Zishan, you can tell. Have you heard the name? Can you write the name, Zunera, in the chat box?
Yes.
Just write down the name in the chat box.
So
Okay.
it's actually spironolactone, but it has less effects on androgens. So it doesn't give the gynecomastia and what was that? Some other effects of the androgens.
Actually, the Zenera, unfortunately, in actually there are two problems. Usually, these drugs are not available in Pakistan. This is number one. And number two, unfortunately, because these number of books, the drugs, they are not written in the textbooks. So usually, no, like because in most part of the world, they are treating Morgan as a textbook. So I am not sure whether it is written in Morgan or not. So usually, these things again, I tell you something, don't tell at the start. This will
Mm-hmm.
be so. This is a dangerous thing. Please don't dig yourself in problem. These uncommon things or newer things, you should tell after telling the common things. You
Or
can
maybe when
make
they ask a question about
no,
that.
no, no, no. Even then, you can tell. Like you can say that traditionally spironolactone is used, but now there is new medication like that. If it is available,
Mm-hmm.
it has this advantage. So you can make your answer like that. Okay,
Mm-hmm.
for all of you, this is my request for all the topics, not only for this thing. The newer things will not fail you. They will not fail you only if you don't know something very, very new. But if you tell and you are not able to defend, it's not available in Pakistan. Maybe the examiner also doesn't know. Okay, even because you are in different part of world, so maybe things are a little different for you. But even then, I will tell you, it's always safe to answer in that way. That traditionally this was a treatment, but usually these are the newer things. If it is available, it's now being used more frequently. You can say like that, and you can make your answer and another boost that in our setup it is available, so they are preferring this thing. You can use this word as well. Okay. Okay. So okay. So in CNS and encephalopathy, uh, especially in alcoholic liver disease, and it is also in being used in treatment of this delirium tremens, which can occur in the patients is acute cessation in alcoholic patients. Okay, so uh, precipitated by infection, GI hemorrhage. So that's why they do this lactulose. Okay, and also neomycin, oral neomycin. So these are the things which will be to prevent. So now they can ask you these questions separately. So you should be knowing. So like again, I coming back that whatever problems then these patients will have, you should be knowing what thing you can do preoperatively. Like from where we started our discussion. So I will come back there. In capillopathy, you should be knowing that this patient may be in more critical situation post-operatively and maybe have post-operative ventilation and ICU admission. So this is one thing. With reference to albumin, if you can correct it. Otherwise, there will be chances, albumin or PTINR, there will be chances of bleeding. Number 2, 3. Okay. And then another very important thing, if you are doing, I forgot to mention at that time, for you all, Zishan, Sheher Banu and Nuzinara also, that whenever there is ascites, even if you have drain, whenever they will open the abdomen, okay, whether it is laparoscopically or whether it is this one open, there will be sudden deterioration of hemodynamics, because as soon as the tamponade effect is gone, there will be sudden hypotension. So either you replace ascites, whenever you replace ascitic fluid, sorry, whenever you drain ascitic fluid, you have to replace with colloids, okay, preferably albumin. Otherwise, patient will have hemodynamic instability. So this is true for not only ascites, also for any free fluid in the abdomen. So whenever they open, you should ask the surgeon, is there, or you should have a look on the CT scan, is there any free fluid? So because in that thing, sudden hypotension can occur. This concept, I hope you understand what is the significance of this thing. So we had just had a look on GI. We had just look on, of course, the reasons, the common causes of liver disease internationally will be like a viral or alcoholic liver disease or some other inborn problems or idiopathic causes. Okay, so you should be knowing the etiologies, okay? Then what are the systemic effects, and practically what is the importance? So again, I'm repeating that long cases in some part of, because for you there will be no long case, Zunera, but in our part of world, in the FCPS exam, there is long case in which there is a patient and they have to do all the examination history, and then they have to summarize a case, and then they have to present to the examiner, and they will be asking the questions. Okay. But
Sir, I
again,
have the same.
you have
I
also
have
have
the same like this. Yeah.
where in EDA, it's not there.
No, I am also giving the Romanian one. So I
Okay, okay,
have, yeah,
okay,
I
okay.
have the same
Okay, so
like,
I hope this will help you.
yeah, yeah,
This
exactly.
will, yes, this will help you over there as well. That Zishan, are you gathering? Sheher Banu, are you still here or she has gone?
Yes, sir. Yes, sir. We are here, sir.
Yes. Okay.
Yes, sir.
Yes. So Sheher Banu, you want to add something in whatever? So now we will go into the some points related to anesthesia conduct. But up till now, anything you want to add?
No, sir.
Okay. So, but I will repeat again, repeating, try to be simple, try to make summary. Okay. And whenever you find a patient is liver failure, I know that you will be taking the history. I'm not saying that you try not to miss any presenting complaint. Okay. But the other questions, try not to be distracted by the patient, because this is the biggest problem, that you only have 10 minutes. Forget about 15 minutes. Only you should be concentrating that you have 10 minutes for history and 10 minutes for examination and 10 minutes for compiling your case. Because if you will not do like this, believe me, you will be in trouble. So try to be gentle with the patient, but try not to be distracted. So don't make questions from the answers of the patient. Quickly try to fill the gap, because you don't have to do a PhD in that patient. You just have to grab the important things, and you have to, your brain should be working that what will be the possible questions. So possible questions you should be preparing pre-hand, that in this patient, yes, you will find some of the findings. Yes, you will be asking the blood group, you will be asking about the blood transfusion, you will be asking about hematemesis and melena and jaundice and everything. Okay. But at the same time, you should be knowing practically what are the things. So this is how you should be proceeding. I hope you understand. So in this way, you will not miss anything. Okay. Because next step will be the anesthesia conduct. So as I startedly, that whatever case is, you should be thinking that you can, whatever things you can optimize, you will do optimization. We have had a few words about that optimization. Then the next step will be towards the basic steps, like optimization is one of them. Anxiolysis, you will do with caution because it can precipitate encephalopathy. Acid prophylaxis will be one consideration. Then airway management. So you will consider the patient as full stomach, but at the same time, rapid sequence induction can have sudden collapse of the patient. So you will say that I will take an arterial line so that I have a better control. And if possible, I will go for modified rapid sequence reduction. But what will be the problem here? That if you are saying rocuronium, then rocuronium is uh, partially metabolized and excreted both through kidney and liver. And both liver and kidney can have some problem. But because if you have Sugammadex, so it is engulfing it and it's an inert. So it will not cause any problem. So you can make your answer accordingly. So you can say even then, can you do rapid sequence induction with cisatracurium? Yes. What will be the answer? Can you make your answer with reference to cisatracurium for modified rapid sequence induction?
Certainly, actually, in hepatic failure, we also have to think about the pseudocholinestrases. They will be
Okay.
less. So, actually, the block with the sucks will be more better.
Okay.
And
So
another thing, the rocuronium is only by the hepatobiliary, no?
excreted both through
It's
kidneys,
80% from hepatobiliary
both.
metabolism.
Anyways, I don't remember the numbers, but I just remember that it is excreted through both pathways. Okay.
So
So
we shouldn't use roc in this case, right? This is what I understand.
yes, I'm just telling you with reference to, like for example, if you what are the problems with succinylcholine in these patients? Is there any
So
problem?
first of all, we have to see like the pseudocholinesterase level, of course.
But in emergency, you don't have time. Okay. So one option
But we
is, of
consider the
course,
patient, if the patient is coming with this cirrhosis or with hepatic dysfunction, the
Hmm.
pseudocholinesterases will be low. Like this is already understood, no?
Very good. You are right. You are absolutely right. So that's why I'm saying to you that if you have the availability of rocuronium versus Sugammadex, because you can reverse it. Okay. Because
So we go with roc, right?
no, I'm not saying again, this is again, don't use the word I will go with this. You can say all medication with reference to neuromuscular blocker, you should be knowing the consideration. You can tell that if I use succinylcholine, I should anticipate prolonged effect. If I'm
Uh-huh.
using rocuronium, it is metabolized by like excreted through the bile, and it can have also problem. So
Uh-huh.
because there is also decrease in SVR, if I'm using atracurium, so it will also release histamine. Okay, so
So
you
that
have to.
what I understood, like the cisatracurium, like other than roc or sucks, we cannot
Cisatracurium
use
is the
anything
safest
else for rapid
for
sequence induction.
maintenance. Cisatracurium is the safest.
Uh-huh. Yeah, of course, because it doesn't have that. It's with the ester hydrolysis, right?
Yes, yes. So agreed, Zishan and Sherbano?
Yes, sir.
Yes,
Sir,
sir.
I think
At the initial
the
dose.
use of succinylcholine with reduced sodium-cholinesterase,
Is
practically,
not a
sir, it's not
contraindicated.
that. Yes, sir,
No,
it's
it's
Contraindicated.
not.
not
Practically,
contraindicated. No.
So again, you will just tell.
we can use it, sir. We can use it if we don't have rocuronium and sugammadex available. Then we have no choice but to use succinylcholine in emergency cases. I think so, sir.
Exactly.
Yes,
Yeah.
you're right. But you can make your answer in a way that these patients can have electrolyte disturbances. So you will make an individualized program. Okay, individualized plan. So if succinylcholine, these problem can occur. If I use, because you would not like to give a big dose of propofol, so still you will try to titrate the doses of propofol, or you may need to use ketamine or midazolam or any other medication which is, or because these patients can have heart failure. So propofol or thiopentone sodium will not be a good choice. So you will be going either for etomidate, or you will go for ketamine midazolam combination. Okay, so you will say that uh, these problems you can face. So you cannot go simple by saying I will do rapid sequence reduction. So you have to, whenever they are asking, they want to listen from you these things. Okay. So you will say that it will be a tricky choice, but if you say, I will take arterial line awake, that will be a safe thing. That will make you much more safe, that I will do an arterial line in awake patient so that I will have a better control on the hemodynamics. I will be looking the risk of aspiration will be there because of full stomach. So I will be ready. Maybe I can consider to have a ramp position. Maybe I can choose according to the according to the situation. If I use propofol or thiopentone or some, maybe I should reduce the doses. And suxamethonium, it's not contraindicated, but you should be thinking that if it's a chronic liver disease, maybe the duration will be prolonged. So these answers you can make. The advantage of rocuronium will be that you can fully reverse with sugammadex, because in such patient, if you have in partial reversal of neuromuscular blockers, there can be problem in the postoperative recovery, because the recovery profile for which you can easily say that recovery profile with rocuronium sugammadex is the best. So of course, this is a controversial thing. So don't use this word to start with, but you keep this information in your mind, and if they are making you a situation in which they are creating problem for your default answer of suxamethonium, then you can use this word. Okay, because in majority part of the world, sugammadex and rocuronium is not available. So you this should not be your first answer, sir. I will use rocuronium. No, I'm not saying like this. So you should be knowing the things. So the miskin and safest is cisatracurium, because neither it has metabolism with the cisatracurium, sorry, with liver, or no relationship with histamine release. Okay, so these are the things which you should be knowing. So you will tell like that.
So can you also elaborate about etomidate?
Yes, etomidate.
Can you, yeah, about etomidate. You are still using etomidate? Like if we have an exam, like of course we have read about etomidate in the pharma, and it has been like in past it has been used. So how we should like go with etomidate in the
Etomidate,
exam,
the
like
only
exam wise?
advantage is that it is not causing cardiac depression as compared to
Yeah,
propofol. So this is the only advantage. But otherwise, it causes adrenal suppression, it causes myoclonus. So,
yeah.
and it is not as fast or not a good ideal agent for rapid sequence reduction. So
So
you
should we point it out in the exam, or we shouldn't just
you
because it
should
has
tell
been
that if
banned
there is
from certain
cardiomyopathy,
countries?
if there is a cardiomyopathy, in
Uh-huh.
cardiomyopathy, the safest choice is etomidate.
I
Or
see.
if you are using a combination with low dose of ketamine or midazolam, things like that. So
I
etomidate is
see.
still being used. I don't like it. I never use it, but I'm just telling
But
you.
it's available in your part, right?
Yes, it's available.
I
It's
see.
available even in Pakistan, I think. Yes, it's available in Pakistan. Sherbanu and Zishan.
Sir,
Sir,
I
I've
never
never
used
used
it.
it.
Yeah, it's available, I think. Okay. So anyway, so in the exam, you don't need to tell that it's the first choice. You will say that if I use this can be the problem. If I use this is the advantage, and this is the problem which I will be facing. So you can make your answer like that. Okay.
But
If you
actually, my question was like, it's okay to talk about a drug that has been banned in certain countries. Like we should know about the drug, and we should know about the pros and cons, right?
Yes, that's it.
It's never a
In the
mistake to
exam,
point it
as I
out.
mentioned to you before as well, Zunera, that you should be like a diplomat. You should be like a politician. You should be using the words in a way that you are not pressing on only one thing. Okay.
Okay.
So again, that they will say that what is the best choice. So you say that it will be individualized plan, because there is nothing safe. This has this problem and this has this problem. Okay. Similarly, like for example, if you go for opioids, the safest opioid is remifentanil. Okay. But otherwise, you can give fentanyl because fentanyl will be low dose. But if you are giving for a long infusions, then fentanyl will create the same problems as morphine. It will delay the recovery. Okay. So maybe you in your exam you should be knowing about all that, what will be the role of alfentanil or sufentanil, because I don't remember, but you should be knowing it. But remifentanil, cisatracurium is safer medications. Okay. Among the volatile anesthetic agents, which has the least metabolism?
Isn't it enflurane?
Enflurane is not
Desflurane, I think.
desflurane.
This, yeah.
Desflurane. It has
Zero
the
point
it,
zero zero 0.002. Yeah.
yes, the simple recall is 20 for halothane, 2% for sevoflurane, 0.2% for isoflurane, and 0.02% for desflurane. It is to remember. Actually, it is written different, less than 0.05, things like that. But for remembering, it's easy formula or easy way to remember. Okay. But again, okay. So these are different. So what about analgesia? Yes. You're saying something? You're saying something? Anyways, so the analgesia plan, because is paracetamol contraindicated in liver disease?
No, it's
Yes,
not.
Is
sir.
doses should be reduced. Am I right, Shehrbano?
Yes,
Yes,
sir.
sir.
Okay. Then NSAIDs, again, there will be high risk of bleeding. Okay. So NSAIDs should be used with extreme caution if you want to use. Opioids we have discussed. Dexmedetomidine you can use, but again look for hypotension and bradycardia. Okay, because usually these patients are hemodynamically unstable, and Presidex is dexmedetomidine is involved, like is associated with prolonged hypotension or bradycardia, and even in post-operative periods. So you have to be careful to use them. Okay, so this is one thing. What about in abdominal surgery, or what about regional anesthesia in liver patients? Can we use epidural or spinal?
We have
So
to
the
see the
epidural is
coagulation
fine.
profile, no?
You always have to do the risk versus benefit. Okay, you also have to always have to do risk versus benefit. If you have corrected the coagulation profile, you can give, but it's always a tricky decision, because not only the one thing we did not discuss is spontaneous bacterial peritonitis, which can occur in these patients, and patient can go to sepsis. So epidural is never a safe option. Okay, of course, even if the numbers are good, still there are more complications which can occur. So again, you can say that risk versus benefit. If there is no compelling indication, it's better to avoid a variable. Single shot spinal, yes, you can consider. Again, you have to think about the hemodynamic problems. So it's always safer. It's I always say not to give central neuraxial block without it's unless until it is strongly indicated. Then about the blocks. So deep blocks should be avoided. Okay. But ultrasound guarded superficial blocks you can give. Like for example, if they ask about tab block, so tab block can be given, and you should just reduce the dose, because the metabolism of local anesthetics is also through the liver. So liver failure will also lead to prolonged duration of local anesthetics. So I think this is the thing which you can tell. Okay, so Child-Pugh score, we all know. Conduct of anesthesia. Yes, they will ask you another question: at what level numbers you will give something, that how much should be the number for platelet, or how much should be. So INR should be less than 1.5, and for major surgery, I think platelet count should be more than 100,000. Okay, and for minor surgery, it is around 50,000, but usually this one. So one more thing I was thinking, that other than standard 1, standard 2 monitoring, you should tell about other monitoring with reference to neuromuscular blocking monitoring, then urine output, okay, and then ABGs, bedside INR. Then we have bedside ACT if it is required. If then this thromboelastography or rotum. So it can guide you about the replacement of blood and blood products if needed. So these are the things which should be telling. Okay, and then you should be looking for hypoglycemia. So be careful about hypoglycemia, and then if there is too much bleeding, then this Novo 7 or PCCs. These are the stop thing, because if the patient is overloaded, you cannot give a lot of FPs or cryoprecipitate. Then you need to give PCC, prothrombin complex concentrate. So you should be knowing what it is. It is a 4-factor or 3-factor, 27910, or I think 279. I don't remember exactly. Okay. So these are the questions which they will be asking you. Invasive monitoring, arterial CVP. CVP is actually controversial. So CVP is not needed unless you need to give vasopressors. Then you will say, but only you cannot say for fluid administration. It's better to have, if you have non-invasive, this cardiac output monitoring. Okay, or even you can get a lot of information from the intra-arterial blood pressure waveform. Okay, so similarly, esophageal Doppler or T is also not safe because it can cause variceal bleeding. Similarly, this one temperature, again temperature probe can also cause bleeding, so you have to be careful. Yes, nasopharyngeal, it is easy to place, but still even in nasopharyngeal there may be bleeding. So it's always tricky. You have to tell that whenever you are doing it, it should be very well lubricated and given very cautiously. Okay. So they have written here temperature, neuromuscular block, because temperature is in standard monitoring. So rest of the things are target control infusion of propofol. Okay, I don't know. I have not used it for anything, but because this is like any other patient. So crystalloid balanced solutions should be given, or according to the electrolyte results you have. So okay, so I PCA with fentanyl tab block, yes, the use of is recommended. You can give, okay. Epidural cautious, as I mentioned to you. So less than 1.5 and more than 100,000, as I was telling you. Intramuscular injection should be avoided. Even if they want to give vitamin K, you can give in IV slowly. I think you can give. Okay. Mm, so I think these are the things which you should be because whenever they're asking you this question, so if it is a patient with the chronic liver disease, these are the things we should be knowing. Endoscopy suit I have discussed separately. I will just tell you few words that in endoscopy suit you can say that it is a non-operating room anesthesia, so limited manpower, and it's a quick procedure usually, unless it's you have to discuss with the surgeon what they are going to do, but usually they are quick procedure. In a number of time it is an outpatient procedure if it is a diagnostic or something. So you can think about a day surgery concerns also. But here, usually these will be a book patients if it is coming in emergency as a bleeding. So you have to, even you should tell that monitoring as well as arterial blood pressure monitoring, as well as you might, if it is sudden bleeding, because it can the hemoglobin can come very low. So you have to inform the family, you have to arrange the ICU, and maybe you need to have this MTP, maybe massive transfusion protocol activation may be needed. So maybe you need to tell about these things. Okay. So I think they have, some people have just put some, so a number of things we have discussed, because actually the purpose of this discussion is to just clear your concepts about a certain disease. Okay. I cannot recall without preparation everything. This is one thing. And number two is that everything is written in the books. You just have to compile your answer. So whenever I take classes, my main purpose is to make you yourself equipped with how to construct the answer, because in very few minutes you have to answer, because they can ask you another way, that you have a patient with the chronic liver disease. He is coming for example, they need to do cholecystectomy. Okay, because now cholecystectomy is not done as an elective. Usually now they are doing it in acute phase as well. Okay, or any other procedure which you cannot delay too much. Maybe for it is not urgent, but you have to do it as a plan. So they can ask you these scenario as well. So you should be knowing how to handle the answer. Okay. So and then with reference to physiology, you should be knowing what are the functions of liver. Okay. Maybe here there are some hepatorenal syndrome. It's here written here. I will just have a bird eye view, because they usually they will not ask too much details. If they are asking you, maybe you this criteria will be more than enough. Usually they will be asking this criteria. Maybe something new comes because it's a relatively older article. If you find something new, you can share. Okay, but usually that there is no other reason of renal failure, absence of shock or ongoing infection. Actually, what's the problem? I don't think so. It's a easy diagnosis because usually these patients have multiple problems. So usually it is very difficult to label the patient as a hepatorenal syndrome. Um, Unfortunately, I think. But for exam point of view, if you just cram this diagnostic criteria, I think that will be more than enough. And there are certain types of renal this hepatorenal syndrome which I don't remember. Okay, so I think you can just have a look here. This is something important. Splanking circulation of cirrhotic patient is dilated due to mediators including nitric oxide, vasoactive intestinal peptide, glucagon, okay, which are overproduced by vascular endothelium in splanchnic and portal circulation and not metabolized by the cirrhotic liver. Yani, like simple, there are vasodilators which are normally metabolized, are not metabolized, and they are in abundance now. This leads to reduced SVR. This is interpreted in turn by JG apparatus as effective hypovolemia. So as I told you, that effective circulatory volume is less. Okay. And the sympathetic nervous system and renin is activated, leading to intense renal vasoconstriction. ADH is activated, giving rise to hyponatremia because there is more water retention, and SIT is associated with cirrhosis. So, aldosterone effect is in the form of hypernatremia, but as I told you, that not necessarily always same sort of electrolyte imbalance will be there. So that's why you should tell electrolyte imbalance, and then you can say that because there is complex pathology going on in liver failure, so different things can occur. In extreme instances, acute cortical necrosis due to renal artery vasoconstriction can occur. The cardiac output in HRS was traditionally felt to be high, but recent thinking puts cardiac dysfunction on a background of cirrhosis as an important trigger for HRS. So this is another, some what you say, cirrhotic cardiomyopathy. So this is how you can just have a look on here. And there is an article on, I think, hepatopulmonary as well. So these are the thing, basically summary again, that on the basis of history, examination, and investigation, you should identify how severe is the liver disease. Okay. And then you will look into consideration all the precipitating factors, the etiology, and then according to different tests or different clinical history, you will identify how big it is. You can optimize something, and then you will make an individualized plan for all the surgeries which is there. So these are very good articles actually. You can get help from these, as we did not had a look in the other article, it was not there. So spontaneous bacterial peritonitis is also there in patient with ascites. Okay, because it will be life threatening if you early recognize. Otherwise, it has very high mortality. Okay, so you will be giving antibiotic, you will be doing the culture, and the same thing. Again, you can use also that these patients maybe you are treating on the lines of sepsis. Okay, so I think I have tried to give you a summary, and because we have discussed before as well. So for some time I miss some of the things because just a second, please. So I will just show you some of the liver. By the way, my channel is not a monetized one, so don't think that I am doing the publicity of my channel. It is all for you guys, okay, and it is for your betterment. But try the bottom line. Remember, try to prepare the answers. Try to predict the answers. Okay. So we have discussed, yes, alcoholic liver disease is also there. So I have discussed, I think, before a number of topics. So you can have a look here. Okay. So in alcoholism, Zinara, because maybe you find more patients about alcoholism. So have you read something special about alcoholic liver disease? I had an article here.
Yeah, we had, but it's like normal here. They are not just coming for that liver cirrhosis because of alcoholism, but they have also other comorbidities because they never showed up in time because of the cirrhosis.
Yes.
They are
No,
coming
no. Yes,
when they
my
are late.
question is that something special about patient with alcoholic liver disease?
Not really.
Okay. So I think this is a also very good source for revision. This is a mind map. Mm, I will just try to show you. So in CNS, there is encephalopathy, neuropathy, okay, cardiomyopathy, a number of things which I've already discussed. Uh, I think AWS is what? Withdrawal, acute withdrawal symptoms, sweating, tremors, some abbreviation haunts, increased reflexes, anxiety, agitation, okay, post-operative complication. So you can just have a look. It's I will share it to you, but usually the common things are the same because usually they are not commonly asked in our exams.
Uh,
Macrocytosis, what?
I think
Uh,
one thing in the patients with alcoholic liver disease,
yes,
and they
Sharma.
have Wernicke's encephalopathy and they are thiamine deficient. So,
Yes.
if they present in the ICU, so we have to start thiamine infusion before starting them on nutrition, because
Okay.
starting nutrition first will worsen the encephalopathy.
Okay. Thank you. Thank you. Actually, in Zenera, in your exam, they can even, I remember, I went for Irish Fellowship exam or EDA, I think I remember, I also learned how much is the like social drinking and how much is going beyond it. So you should read about it. I remember in one of the FRCA book, I think in the oral structured oral examination book, it's written. So you should be knowing about it. Okay.
Yeah, the you are talking about the quantity, no? The 450 per week.
Yes, something like that. Yes, I don't remember
Uh-huh.
exactly,
Yeah.
but it's been 9 years since I appear in that exam. So, okay. So thank you very much. I think I will stop here. So I will share this link to you guys, and we will just try to cover some other unit because the liver transplanted patient, they can yes, another scenario that a patient who was having liver transplant before and now coming for any surgery. So you have to take care of the organ perfusion. This is one thing. The patient may be on lifelong immunosuppressant. So things related to immunosuppression will be there. And certain procedure, like they are coming a number of time, they are coming for routine checkup or some this strictures. In acute phase, they can come liver transplanted patient for there is a graft failure. So these are one of the most difficult patients to handle. uh, it's less likely to be asked about liver transplant, but usually there is a dissection phase, then anhepatic phase, and then perfusion. So usually in dissection phase, we don't give fluid. Okay. In anhepatic phase, we just try to correct all the correctable things. Okay. Whether it is electrolyte, whether it is acid base, we can give some fluid. Okay. And when they reperfuse, okay, when they reperfuse at that time, patient can suddenly have a gush of metabolites and patient can collapse. So at that time, you have a baseline infusion of norepinephrine, okay, and you can, as I mentioned, and in an hepatic phase you have to correct all the correctable things. So these are the common things which they can ask you about liver transplant. Okay, so thank you very much. I will stop here, and like for any questions, you all are welcome. Zishan, in previous exam, do you remember any questions related to liver, which was like you can share here or share, Bano, like anything special which you heard? Yes, Zishan.
No, thank you so much.
Okay, so thanks a lot for joining. Inshallah, we will meet again. Assalamu alaikum.